So the topic has already been spelled out by Dr. Talwar. It's diabetic cardiomyopathy. So whenever a patient of suffering from diabetes, be it type 1 or type 2, presents to us, the big question is it diabetes per se which is causing the problem, or is it some underlying other pathology? Maybe in adult patients, is it most commonly coronary artery disease, or maybe at the macrovascular level and even at the microvascular level. So that brings us to our topic, whether diabetes per se can cause cardiomyopathy, which we refer to as diabetic cardiomyopathy. Now, there have been three papers related to this which have been presented in ADA this time. One was on the cross-sectional analysis of a large cohort of patients with diabetic cardiomyopathy enrolled in a longitudinal study. It's called the ARISE HF trial. Then we had another trial showing how to diagnose diabetic cardiomyopathy at the early stages based on the circulatory biomarkers. And then we had also some presentation on molecular mechanisms of diabetic cardiomyopathy. So starting from the clinical aspect to the molecular level, we had a lot of presentations in ADA this time on diabetic cardiomyopathy. So before I talk about the trials which are presented, so what is the entity of diabetic cardiomyopathy? As I said, whether diabetes itself can cause damage to the cardiac musculature, its structure, and its function. Yes, it can, as the presentations show and as we have known. So, diabetic cardiomyopathy basically presents to us in the stage B of heart failure, the stage B that has been we have been reading about it from 2013, when 4 stages of heart failure, as you know, stage A, stage B, stage C, and stage D were enumerated. So stage A is largely the presence of risk factors which we have known to be precursors of heart failure. Stage B, actual structural and functional alterations take place. Stage C is, of course, overt heart failure, and stage D is refractory heart failure. Now, diabetic cardiomyopathy, where basically it is diabetes only presenting with a cardiac muscle structure and functional abnormality, can affect both type 1 and type 2 diabetes. So that is the first point that should be highlighted. Now, as I said, it is a stage B heart failure, which we refer to as diabetic cardiomyopathy, because when patients present to us later on, it may be a conglomeration of other other conditions also. It can be coronary artery disease, it can be CKD. But basically, our main focus of today's discussion is how to identify diabetic cardiomyopathy at this earlier stage, that is stage B. Now, mind you, as I said, already while in stage A, the metabolic derangements already start in the cardiac musculature, but it is basically in stage B that we come to diagnose this with the various tools that we have, either in the form of cardiac biomarkers or specifically with cardiac echocardiography in its very advanced form, including tissue Doppler imaging, strain imaging, etc. Now, one common thing which patients often come and tell us, doctor, I'm not feeling as strong as I used to be. My functional capacity has been reducing over time. Now, this is often we tend to ignore, and we take it as either some psychogenic abnormality or we ascribe it to some other factors. But this is something we have to take with all seriousness, and because that is the starting point of diabetic cardiomyopathy. And as we progress from stage A to stage D of heart failure in patients suffering from diabetic cardiomyopathy, there is a progressive decline in the functional capacity. So if we say the functional capacity is X in stage A, there is a 25% decline from stage A to stage B, and there is approximately another 25 to 30% decline as we progress from stage B to stage C. So this is something, one of the points to be highlighted. Now, how to diagnose diabetic cardiomyopathy at the earliest stages? So Basically, echocardiography is a tool which is readily available to most of us cardiologists and even to other specialists as well. So basically, we look at the total LV mass, that is one of the first abnormalities, then the left atrial volume index. We look at the E by E prime ratio, that is at the diastolic filling abnormalities, and a very important tool which has been available to us in last 7-8 years like that is strain imaging. Now strain imaging, we have found out it begins to decline right from stage A, and the decline is all the more evident in stage B. So whenever you are advising for assessment of a suspected case of diabetic cardiomyopathy, you always insist that the patient undergoes strain imaging not only of the left ventricle, but I would recommend also of the left atrium. So this strain imaging is very important entity which should be highlighted. And we can add to this assessment of the systolic pressure or pulmonary artery systolic pressure. Apart from that, I mentioned about the biomarkers. The main biomarkers are NT-proBNP and high sensitive troponin. And as I'm going to tell you later, that there is a prediction which can be based on NT-proBNP measurement. And of course, whenever we are diagnosing diabetic cardiomyopathy, we have to exclude concomitant significant valvular heart disease, coronary artery disease, any congenital heart disease in the patient, and whether the patient has uncontrolled hypertension. So, just to recapitulate quickly whatever I've said, don't ignore the complaint of physical poor exercise tolerance from the part of the patient. Take it seriously, assess it with biomarkers, and do a full-fledged echocardiographic study. Now, another very important tool in our hand to assess the patient's functional capacities, of course, cardiopulmonary exercise testing, which measures the VO2 max. And if that is a tool available to us, that is also very sensitive. As I'm going to tell you in one of the trials measured, that is one of the primary endpoints in terms of VO2 max assessed. So that is also a very important tool to assess patient's functional capacity. Now coming to the trial that was presented by one gentleman from Massachusetts, New England, Dr. Eskowitz. It is a trial called ARISE Heart Failure. It is an efficacy study to evaluate the ability of a novel and highly selective aldose reductase inhibitor, AT-001, to prevent the worsening of diabetic cardiomyopathy. So aldose reductase, as you know, converts glucose to sorbitol, and this sorbitol and its other products in turn causes a lot of damage to cardiomyocytes. So this is one of the endpoints. As you know, glucose is a very energy efficient molecule. So on one hand, there is energy depletion of the cardiomyocytes. On the other hand, because of increased aldose reductase activity in the cardiomyocytes in diabetes, there is production of sorbitol, which can cause further damage by increasing the osmotic stress, by causing oxidative damage, and by promoting cell death or apoptosis. So this is the trialists are looking at. About 675 patients have been enrolled, and they have been divided into 3 groups. One is the placebo group, and the other 2 groups have been given 2 dosages of this new molecule AT-001 in 2 dosages, 1000 milligram BID and 15 milligram BID. And the primary endpoint, as I said, is the functional capacity measured by VO2 max by CPET, cardiopulmonary exercise test. There are a number of exploratory secondary endpoints also. So they being the progression to overt heart failure, then a measurement of serial NT-proBNP, and the quality of life score in the form of KCCQ score. So this is in nutshell about the study. The study is ongoing, but some facts have emerged already, which has been presented in the ADA this time. So these patients were already on the state-of-the-art medical therapy. They have been receiving statins, they have been receiving RAS blockers, and they have been receiving the various oral hypoglycemic agents that are available, and also insulin. In fact, almost 20 to 25% people who are receiving SGLT2 inhibitors and GLP-1 receptor agonists in this trial. So patients were already on the state-of-the-art medical therapy, and on top of that, this new agent 80001 was being tried. And in fact, 10% of people were receiving both SGLT2 and GLP-1 receptor agonists. So if this new agent 80001 produces some productive results or I mean outcomes, then definitely it is a molecule for the future. Now, what about this new molecule? We have had aldose reductase inhibitors in the past, mainly used for coronary, diabetic microvascular complications. Yes, they were successful to some extent, but they produced not very potent in the first place, but they had also some side effects because of aldehyde reductase inhibition also. So this time we have a more safe and more potent and more selective aldose reductase inhibitor that is being tried, which is called 80001. Now, serial NT-proBNP screening, as I said, is going to be done in the trial. Now, whatever results are available, now the VO2 max, the primary endpoint, has been divided into 4 quartiles. The lowest the quartile 1 has a very low VO2 max of 10 point something, and the best one, the quartile 4, has more than 20. What has been found out that people who have who are on SGLT2 inhibitors and GLP-1 receptor agonists tend to fare better as expected. And another thing which has been found out that those who have very high NT-proBNP at the baseline, they tend to fare worse. So, as I just to highlight the points again, NT-proBNP is a very useful marker. The next study that I'm going to present is one from Professor Januji, who presented the diagnosis of diabetic cardiomyopathy based on the circulatory biomarkers, and he came to a very strong conclusion that anyone with an NT-proBNP level more than 125 picogram per ml are at a very high risk of further cardiovascular events, the most common being heart failure hospitalization. So if you, it is likely that the ADA will come up with a guideline to assess NT-proBNP and also HS troponin I or troponin T, whatever is available, at least once annually in all patients of stage A and stage B heart failure. And those who have NT-proBNP less than 25 picogram per ml are better off in that they have a very low risk of cardiovascular events and heart failure hospitalization. So this is one of the very strong comments that this trial, the second trial on circulatory biomarkers, have come up with. And coming to the last part of my presentation about the mechanisms at the molecular level, what is diabetic cardiomyopathy? Why is it happening? Now, as I've already said, so if aldose reductase activity is increased in the cardiomyocytes, what happens? We have less of glucose and more of free fatty acid oxidation. So that is not energy efficient for the cardiomyocytes. So there is energy depletion on the one hand. On the other hand, there is more of osmotic stress, there is more of oxidative damage, and there is more of apoptosis. So this is something which is this new agent, if it is successful, as is being studied in the ARISE heart failure trial with 80001, is going to show us whether aldose reductase inhibitions selectively can prevent the progression of diabetic cardiomyopathy from stage A to stage B or even to stage C. So this is something we are going to find out from this trial of ARISE heart failure. So to conclude, I'll highlight the major findings on diabetic cardiomyopathy and what is the take-home message. So the major message is that cardiac mitochondrial insulin resistance occurs in diabetic cardiomyopathy. So that is all what we know. And myocardial glucose oxidation is markedly decreased in diabetic cardiomyopathy. Myocardial fatty acid oxidation increases in diabetic cardiomyopathy. Myocardial ketone oxidation is also decreased in diabetic cardiomyopathy. So stimulating glucose oxidation by inhibiting pyruvate dehydrogenase kinase can lessen the severity of heart failure, and increasing ketone supply. In fact, SGLT2 inhibitors does that to the heart, can increase cardiac energy production in diabetic cardiomyopathy. So with that, I'll end my presentation. Thank you very much.